treatment of limb deformities in general goes back thousands of years. Like there are writings from 1000 BC in India detailing treatments for like clubfoot. I'm going to begin in the late 1800s, early 1900s, which is kind of considered to be the beginning of the modern era for surgical limb lengthening. And as Dr. Dunbar's already pointed out, we can learn a lot from history. Orthopedics and medicine in general kind of builds upon itself. That's why we write papers and try and disseminate that little bit of knowledge we get as individuals. Because when you work together as a profession, the knowledge base of everyone grows, and that includes working with our predecessors and knowing our history. So in limb deformity surgery, we can kind of see this progression in action. Individuals didn't usually achieve the results they were hoping for within their careers, but then they had, everyone kind of built upon themselves until we went from simple acute distraction with these really rudimentary external fixators to the Ilizarov fixator and even past that now. The first round of innovation with limb lengthening lasted from the late 1800s to the 1930s. It's impossible to separate the development of medical innovation from the historical context, as we've kind of pointed out already. And this is a time when tuberculosis was epidemic in Europe, causing chronic osteomyelitis and skeletal deformity. World War I increased the need for post-amputation and deformity care. And then, as Dr. Dunbar mentioned, sanitation and aseptic techniques were improving surgical outcomes at a rapid pace as people started to wash their hands and kind of wear gloves and things like that. So within this context, we find Alessandro Codevilla of Italy, who was actually the general surgeon who first described the Whipple procedure. But his hospital was kind of like, we have a ton of orthopedic deformity. We need you to take care of these orthopedic patients. So in 1905, he began experimenting with distraction osteogenesis and described his method for acute femoral lengthening. And it was really acute. He basically performed an osteotomy, put on a spica cast that was attached to a transcalcaneal wire device, split the cast, and then used sudden traction to achieve up to 8 centimeters of lengthening at once, which he held by repairing his plaster cast. Unfortunately, he noted in his writings a delayed reaction, which occurs in the central nervous system, which shows itself in convulsive attacks, which will necessitate the cessation of traction. Basically, his patients were seizing and going into shock because he was lengthening their sciatic nerves by like 8 centimeters at once, which isn't super comfortable. And then his pin bar device was complicated by necrosis around the ankle and heel, which, as we know, is like a huge problem. But he worked extensively with Vittorio Pucci, who was his protege, and took over the chief of staff position at Rizzoli Institute in Italy upon Codevilla's death in 1915. His work at the Institute was greatly influenced by World War I and the ongoing TB epidemic. Both led to huge influxes of patients with limb amputations, deformities, and limb shortening, and he expanded the hospital to care for these patients, continuing Codevilla's work on distraction osteogenesis and researching and improving limb prostheses. He was actually a historian himself who wrote a whole treatise on historic artificial limbs, which you can still find online. But perhaps his greatest contribution to the technique of limb lengthening was the introduction of continuous traction and gradual lengthening. In a description of his method, he advocated for continuous traction to overcome the elastic resistance of the soft parts gradually and without excessive effort, which might be dangerous. And he had actually seen those dangers firsthand in his work with Codevilla. He also introduced the rudimentary external fixator, which he called an osteon. It was basically just 2 pins fixed proximal and distal to the osteotomy with a telescoping tube in between that could be lengthened to facilitate distraction over time. And using the osteon avoided pressure on the skin that had plagued Codevilla's transcalcaneal wire, and the limb didn't need to be in a full extension as it did in Codevilla's spica cast. So contemporaries of Pucci expanded on its use of the osteon, developing their own external fixators for slow, constant distraction. 2 of these were August Beer and Leroy Abbott, and they both separately advocated for a 10 to 14 delay between osteotomy and distraction. Abbott delayed his distraction for 2 reasons. One, he wished to allow the soft tissues time to heal and swelling to decrease so as to avoid complications related to necrosis and compartment syndrome. And 2, he recognized that the early callus that formed in this delay period could then be modified through distraction, improving the stability of his regenerate. His contemporary Beer theorized that the delay would allow the body to exploit the healing stimulus of the hematoma that was formed by performing the osteotomy. He had noted robust formation of bone around fractures where the hematoma was left alone and extended this principle to limb lengthening. But unfortunately, both of these people failed to recognize the healing potential of periosteum and the other soft tissues. And so they're both advocating for careful stripping of the bone during the osteotomies, leading to aperiosteo callus formation with really weak regenerate. It wasn't actually until the 1930s that Habush and Finkelstein advocated for osteotomy of the tibia without dividing the periosteum, noting that this favored more rapid deposition of callus and bony union. And they also advocated for early weight bearing in a plaster splint that was reinforced with iron walking bars to take some force off the healing bone and further stimulate bone growth. So at the end of the 1930s, we kind of have the bones, of modern limb lengthening principles. Putti was advocating for gradual distraction, Abbott and Beer promoted delayed distraction, and Habush and Finkelstein had discovered the benefits of periosteal preservation. And these are all principles that we still carry on today, and kind of the modern principles of limb lengthening surgery. But unfortunately, the majority of the experimental osteotomies, these custom external fixer devices people were designing, and the unique methods of internal fixation they were trialing, like kangaroo tendon and ivory bone screws, ended in complications. So multiple leaders in the field separately reported on these devastating complications, death, shock, infection, and concluded that the risks weren't worth the minimal lengthening that was often achieved. Even Abbott, who was basically the most experienced limb lengthening surgeon of this period, advocated for contralateral limb shortening over limb lengthening due to the numerous complications. So the end of the 1930s kind of brought about a pause in this field of research. It didn't last for a long time, however, because the 1940s and 50s gave rise to multiple international conflicts that sparked renewed interest in trauma and post-trauma orthopedic care. There was improvements in anesthesia that occurred on the battlefield, and it also drew attention to the importance of rehabilitation. In addition, there were multiple polio epidemics between 1948 and 1955, the sequela of which left some patients with significant limb length discrepancies and other orthopedic deformities that needed a new sort of care. In the West, between kind of 1940 to 1970-ish, things generally stayed the same. We jump a little ahead in our timeline here to the late 1970s, where Wagner of Germany was kind of the leader of limb lengthening in the West at that time. So he's pretty notable for advocating for very careful preoperative evaluation and patient selection. He took into account the difficulty of the procedure mentally, prolonged external fixation, the need for frequent follow-up, and the ability to rehab extensively after surgery. These concepts are still very much relevant today. Good patient selection is just as important and usually more important than good surgical technique. And Wagner's technique was still super aggressive. It really hadn't changed much since the 1930s. He advocated for extensive soft tissue resection, circumferential incision of the periosteum at the osteotomy site, acute distraction until the bone was stabilized by the soft tissue tension, because nerves really like that, and rapid lengthening, followed by immediate removal of the X-fix, iliac crest grafting, and plating across the gap, which wasn't super successful. His results were plagued by non-union, poor regenerate, and soft tissue-related complications, basically everything they had been dealing with 40 years later. But you might be wondering, why are we even talking about Wagner's technique in 1970? Where is Ilizarov? Didn't he start doing all this stuff in the 1950s? Well, as I hope we've kind of made clear, orthopedics doesn't exist in a vacuum. After World War II, political tensions between the Soviet Union and Western Europe and America hampered the exchange of medical knowledge. Ilizarov was working in relative obscurity in Kurgan, which is in Southwest Siberia, in the 40s and 50s. This is a highly medically and socially isolated location. His patient population had a very large burden of post-traumatic injuries from the war, tuberculous osteomyelitis, and other chronic infections, and he didn't really have a ton of resources to work with. In 1951, he began developing an external fixator system to stabilize osteotomies and non-unions with minimal soft tissue disruption. Early models were based on the shaft bow harnesses for horses favored in the area, and fashioned from used bicycle parts. By the 1960s, he had done his first successful lengthening of a lower extremity by 25 centimeters, and the patients in the region were kind of starting to give him the nickname the magician from Kurgan, just because he was healing all of these bones that nobody had been able to heal before. But unfortunately, he was still facing widespread skepticism from the medical community of the Soviet Union. But he kind of got his breakthrough there in 1968 when he operated on the injured foot of Valerie Brumel, who was the 1964 Olympic high jump champion, who has what sounds like a Lisfranc injury that multiple people had operated on and was basically facing amputation. So he saved the Olympic high jump champion, and then he also defended his doctoral thesis and finally gained some recognition within the scientific community of the USSR, the Soviet Union. But he really didn't become known in the West until the 1980s, when he was introduced through the outreach work facilitated by Thor Heyerdahl, this guy on the left, and a group of Italian surgeons. Heyerdahl was a Norwegian anthropologist who decided to unite people from all over the world and also study ancient forms of transportation by having a group of people sail from Morocco to Barbados in a reed boat. Among the crew were both Yuri Sienkiewicz, who was a Russian pulmonologist who was friends with Ilizarov, and Carlo Mauri, who was an Italian alpine hiker who was friends with a bunch of orthopedic surgeons in Italy. Mauri had a horrible open tibia fracture that was complicated by septic non-union with a persistent draining sinus. And basically everyone he had seen in Italy told him his only option at this point was an amputation. But on this boat trip, Sienkiewicz encouraged him to go seek out treatment with Ilizarov. And so when Ilizarov healed his tibia, Mauri convinced the Italian surgeons to learn about Ilizarov's method and this fancy apparatus he was using up in Russia. And they flew Elizarov to Italy in 1981, and he trained the Lecco surgeon in this technique, and they subsequently trained other surgeons. Surgeons like Giovanni de Bastiani subsequently wrote extensively about Elizarov's techniques for a Western audience, even adapting the principles to work with different devices, such as his modular modification of the Wagner external fixator. So Elizarov, what was Elizarov doing up in Siberia? His research centered around defining the ideal working parameters of what he called the tension stress effect. In a series of papers, he had investigated the tissue response to gradual stretching in multiple ways, radiographically, microscopically, biochemically. And ultimately, he found that the tension created by gradual distraction stimulated the formation of not only bone, but also skin, blood vessels, peripheral nerves, and muscles along the lines of tension under very specific conditions. In his first paper, he talked about the importance of soft tissue preservation and stability. And we saw how Bush and Finkelstein had been advocating for preservation of periosteum back in the 1930s, but they were still performing relatively extensive soft tissue releases to facilitate distraction. Elizarov, by contrast, found that a very minimal soft tissue dissection was ideal for robust osteogenesis during distraction, very low energy surgery. The other conclusion from that paper was a need for stability. Highly stable fixation facilitated more robust, more organized osteogenesis. The ring fixator that began with basic bicycle parts was key to his technique because it not only facilitated stability, but also allowed for gradual correction of angular and rotational deformities by adjustment of the relationship between hinges, rings, and wires. In his second paper on the tension stress effect, Elizarov focused on the rate and frequency of lengthening. So he saw Putti in 1920 advocating for slow distraction, but Elizarov really honed in on exactly the amount and frequency that you needed. He found that 1 millimeter per day at a rate of 4 times per day allowed for reliable, well-organized regenerate that consolidated reliably within 3 months. Anything with lower frequency or higher amounts led to a fibrous union, and high frequency or low amounts led the risk of consolidating too early. And two other principles that were pretty pervasive throughout these papers was calostasis and consolidation. So calostasis, or delayed distraction after osteotomy, allows some fracture callus to develop, which is then distracted, which we saw Abbott theorizing in 1920. And then in terms of consolidation, he basically left the X-fix on until the osteotomy had fully healed and then removed it, instead of what we saw Wagner doing, which was taking it off and then plating and kind of disturbing the whole fracture environment or osteotomy environment. So combining the versatility of the fixator with the careful application of these principles allowed for an extremely wide range of uses: congenital deformity, non-unions, acute trauma, bone transport, and even fixing soft tissue conditions that didn't even have bony deformity, because as he showed, the tension stress effect affected the soft tissues as well as the bones. So by the late 1980s, early 1990s, Elizarov's work had begun to disseminate throughout the global medical community just in time for the rise of computer technology and more advanced material science to facilitate innovative applications of his principles. And while his ring fixator is still widely used, the rise of advanced computing technology has facilitated the development of increasingly complex variations on his original idea. Probably the most commonly referenced computerized hexapod fixator is the Taylor spatial frame, which was the first on the market in 1995. But a bunch of variations on this device have been created after their patent kind of expired. They all work in generally the same way. 2 rings are connected by oblique struts that are adjustable and moved a little bit each day to change the relationship between the rings and achieve gradual correction of a deformity with or without additional lengthening. And each of these frames comes with associated software that can be used to plan the deformity correction based on given parameters, and will provide a daily schedule of adjustments for each strut. These adjustments can be made by the patient at home, facilitating ease of care in theory, as long as patient selection is careful. And then moving even further away from Elizarov's original fixator is the intramedullary device. So the very earliest lengthenings over intramedullary devices were in the 1950s by a group at the San Francisco Shriners Hospital for children who had polio or tuberculosis. And this was prior to the spread of Elizarov's principles, of course. So they continued to perform aggressive surgery that hampered their results, but they did find that the rush rod gave great control of the fragments being lengthened with this traction counter-traction device. But the first modern intramedullary devices are attributed to Bliskunov in Russia in 1983, and then Albizia and the intramedullary skeletal kinetic distractor. These devices were effective because they avoided external fixation and facilitated limb lengthening, but each lengthening required that the patient or the surgeon physically rotate the leg and therefore the rod components, which isn't particularly well tolerated and could be pretty inconsistent. So it wasn't until the development of motorized devices, either magnetic or radio transmitter controlled, that intramedullary lengthening really took off. Early versions required patients to be in the hospital to have, or the clinic to have the device activated and lengthened, because the machinery that did that was really big and not really transportable, which if you think that they need 4 times per day, lengthening is a pretty large burden of care. But advances have allowed the development of small handheld devices that they can take home and can be easily used by the patient after a short training period, allowing for at-home lengthening. So it makes this method of lengthening much more accessible. And as with most new technologies, as surgeons become more comfortable with the basics of the devices, they started pushing indications. So with nails and ring fixators, we can do a bone transport for acute trauma with significant bone loss. Some people use them for assisting fracture reduction intraoperatively. Very small patients sometimes have the intramedullary devices used as extramedullary devices, and they're actually in the works developing a mechanized plate to kind of replace this off-label indication, but it's not FDA approved. And then because the intramedullary devices, you can't see them, they're easy to use at home, et cetera, et cetera. Some people are starting to do cosmetic lengthenings for short stature, which is a pretty big jump from where Cotavia was doing 8 centimeters of distraction and sending his patients into shock. So it was pretty quick. I probably could have done like a lecture series, but hopefully you can see how each generations of surgeons were able to build and expand on the work of their predecessors, even if the path wasn't always super linear. I think a lot of us see the intramedullary lengthening nails or those hexapod frames and can appreciate how innovative those technologies are for dealing with complex problems. But I don't know, with history, it's really cool to see how that technology was born out of necessity for patients with tuberculosis or polio, and how they started with these super simple external fixators and they just got more complex with time as we kind of worked, within the context of material science and computer science and necessity. So in summary, history is great. Thank you.